We will start the session. Please take your seat. Okay, thank you. So I'm Didier Samuel, and I will co-chair with Professor Shiv Sarin this session of liver cancer, hepatocellular carcinoma. We will have the discussion at the end of the 3 talks, and we will start right now. So, Shiv.
Thank you, Didier, and we thank Patrick and this very great meeting, and it's a pleasure and honor to hear and chair this session with Professor Samuel. I have the distinct pleasure of inviting Valerie Paredes, a very well-known pathologist who is the chair of pathology at Bujon and has a special interest in liver pathology. And we look forward to a new topic from her, HCC and metabolic syndrome. Valerie.
Thank you, Shiv. Good afternoon, everyone. First of all, I want to thank the organizer and especially Patrick Marcelin for their kind invitation. So, as you all know, hepatocellular carcinoma is one of the main complications of cirrhosis, arising in patients with known risk factor for chronic liver disease, including alcohol abuse, including viral infection with HBV and HCV, and more recently recognized metabolic syndrome. Metabolic syndrome is defined by a constellation of clinical and biological problems, including obesity, diabetes and insulin resistance, hyperlipidemia, and hypertension. And metabolic syndrome can target different tissues, including the liver, leading to non-alcoholic fatty liver disease, which encompass a wide range of liver changes, such as steatosis, steatohepatitis, and fibrosis. You have here the global prevalence of non-alcoholic fatty liver disease in general population worldwide diagnosed with ultrasound or other imaging modalities. And as a consequence of the increasing prevalence of non-alcoholic fatty liver disease, non-alcoholic fatty liver disease is becoming the leading risk factor of hepatocellular carcinoma, as shown in this large US database. And more recently, from the study of scientific registry of transplant recipients, showing the highest increase in HCC prevalence in liver transplant candidates with NASH compared to HCV, HBV, and alcohol consumption. As for the other risk factor for chronic liver disease, hepatocellular carcinoma developed in patients with metabolic syndrome follows a multi-step process of carcinogenesis with cirrhosis at the main risk factor. And you can see on this slide that the yearly cumulative incidence of HCC in cirrhotic patients associated with NASH and compared to HCV infection. In fact, this incidence is not significantly different between NASH and HCV cirrhotic patients. What about the specific oncogenic risk factor for developing HCC when the patient is known to have a metabolic syndrome? Among the different risk factors defining the metabolic syndrome, at least 2 of them, obesity and diabetes, are clearly associated with the risk of developing a liver cancer. Just to illustrate that point, first of all, for overweight and obesity, you can see on this meta-analysis the positive link between obesity and risk factor of liver cancer. Same kind of meta-analysis showing the strong association between diabetes and hepatocellular carcinoma. And very recently, the relationship between diabetes and liver disease in the context of metabolic syndrome, cirrhosis and liver cancer has been also confirmed in this large, very large prospective study for China. 5.8% of participants had diabetes at baseline, and you can see the risk factor for developing an hepatocellular carcinoma when you have a diabetes. And they also showed that the plasma glucose levels were positively correlated with liver disease. What about specific features of this hepatocellular carcinoma? I would like to start with a clinical case. It concerns 61-year-old patients with increased body mass index, hypertension, and dyslipidemia. He was referred to the hospital for abdominal pain. Imaging was performed and identified large liver nodules in the left lobe, hypervascular, with a washout at the late portal phase. You can see that the background liver was not cirrhotic, and a biopsy of the tumor and also on the non-tumoral liver were performed. The diagnosis of the tumor biopsy was well-differentiated HCC, arising in a quite normal liver with a slight, mild intensity of steatosis and just a small amount of fibrosis. So the patients were operated and the left hepatectomy was performed. You can see here the nodules, more than 5 centimeters, and some non-tumoral liver. The definite diagnosis of the tumor was confirmed the diagnosis of hepatocellular carcinoma, well to moderately differentiated hepatocellular carcinoma. You can see that the tumor was well limited, encapsulated, and that the background liver was not so damaged. So this clinical case illustrates perfectly well the new carcinogenetic model that we observed in patients with HCC related to metabolic syndrome. And in a previous paper, we report our surgical experience in such patients. And you can see that compared to patients with HCV or chronic alcohol consumption, the patients with metabolic syndrome develop hepatocellular carcinoma, but in 2/3 of cases, there was not advanced fibrosis in the background liver compared to 26% in the control group. These results were further confirmed at a lesser extent using large clinical studies, showing, for instance, in England, that in patients with HCC related to NAFLD, 23% of them did not display advanced fibrosis. And in this large American series, you can see that HCC developed in patients with non-alcoholic fatty liver disease without cirrhosis in 35% of cases. Other features can be also observed, and in our surgical series, usually the tumor was large, and despite the big size of the tumor was well differentiated. And then in that patients with metabolic syndrome and NAFLD, we can summarize the 3 different morphological patterns of development of HCC. First pattern, common one, occurring in approximately 30 to 30% of patients, development of a middle-sized tumor in a background liver of cirrhosis, and the tumor is usually moderately to poorly differentiated. A main subgroup of patients who develop large tumors, very well differentiated, with steatosis and very low amount of fibrosis in the background liver. And in a small subgroup of patients, the hepatocellular carcinoma may develop from a pre-existing hepatocellular adenoma. Following this first study, we would like to identify some genetic abnormalities in HCC related to metabolic syndrome, and we were able to identify a specific chromosomal abnormality, amplification of 6p to 1.1, that lead to the overexpression of culin-7, which is an E3 ligase, a protein involved in the proteasome. And you can see, both by Western blot or immunohistochemistry, a strong overexpression of culin-7 in HCC related to metabolic syndrome. In addition, the group of pathologists from New York describe a new morphologic variant of HCC, mostly observed in these patients. And interestingly, this morphological variant, called the steatohepatitic variant, recapitulates perfectly well the liver changes that we can observe in the non-tumoral liver, including steatosis, balloon cell, myeloid ink bodies, inflammatory infiltrates, and also pericellular fibrosis. According to these studies and two more studies, one for India, one from Japan, this variant seems to appear in approximately 1/3 of patients with metabolic syndrome. Usually we can observe some degree of non-alcoholic steatohepatitis in the background liver, but so far this variant has not a poorer or a better prognosis compared to the other or conventional hepatocellular carcinoma. You are well aware with molecular classification of HCC, and this one from the group of Jessica Zuckman-Rossi. And you can see that this steatohepatitic subtype is clustering with the G4 subgroup of hepatocellular carcinoma. However, there were no specific genetic alteration that were described in that study. And what we can say is usually these tumors are display a low aggressiveness phenotype with a lower amount of satellite nodule or microvascular invasion. Interestingly, they activate the inflammation pathway. What about the molecular mechanisms in that context? As I said, since we observed much more cases of HCC without advanced fibrosis in the background, it suggests that specific mechanisms, molecular mechanisms, may be involved. And in fact, these molecular mechanisms are more related to the underlying liver disease, NAFLD, rather than to fibrosis. And then you can recognize on this slide the main molecular pathway that are involved in the progression of the NAFLD, of the disease, the NAFLD, but also in hepatocellular carcinoma. The diet is very important. There are some genetic factors. Of course, lipotoxicity is very important, the activation of inflammatory pathway, and also non-liver tissue, including adipose tissue and also microbiota. I will not go into the detail, but I would like just to share with you this very important paper published in Cell a few months ago, suggesting that in obesity, NASH, fibrosis, and HCC can be dissociated. They focus on STAT1 and STAT3 signaling pathway, which are commonly increased in obesity. And what they found using experimental model is that attenuating the enhanced STAT1 signaling, preventing T-cell recruitment, NASH and fibrosis, but no hepatocellular carcinoma. By contrast, correcting STAT3 signaling, preventing HCC without affecting NASH and fibrosis. Last year, we wanted to study the regulation of several adipokines in the context of hepatocellular carcinoma arising in patients with HCC, and we looked at this adipokine, fatty liver binding protein 4, which was initially presented as an adipokine produced only by visceral adipocytes. When we study the expression of this adipokine in HCC, in patients with metabolic syndrome compared to HCV or other risk factor, you can see a very strong upregulation of this adipokine. But more importantly, we were able to identify that the FABP4 produced in hepatocellular carcinoma was mostly restricted to the periendothelial tumoral cells. So we looked at the regulation of FABP4 in liver sinusoidal endothelial cells, and we were able to identify high level of glucose, insulin, and also VEGF-A as important mediator stimulating the expression of FABP4. And using experimental model, two different ones, heterotopic xenograft HFD model and orthotopic xenograft HFD model, we were able, using a specific inhibitor of FABP4, to reduce the tumor volume in both models. So in conclusion, metabolic syndrome is a now well-known risk factor for non-alcoholic fatty liver disease. Its prevalence is growing worldwide and is becoming the leading risk factor for HCC. Diabetes and obesity are independent factors for HCC development, but I like to stress that very commonly cofactors may be present, and especially alcohol, and maybe instead of NASH, we should call BASH for both alcohol and non-alcoholic steatohepatitis. Regarding HCC related to NAFLD, it's now a new model of liver carcinogenesis, since HCC without underlying cirrhosis are more often observed compared to other risk factors. There are specific molecular mechanisms that involve genetics, diet, microbiota, adipokines, and so on. And there are, for sure, still issues that remain to be solved, especially regarding the screening program and maybe the treatment. And I would thank you for your attention.
Thank you, Valérie. So we'll have the discussion at the end. And we will move to the second speaker, Professor Peter Galle from Germany. Will discuss the discrepancy between the EASL, ASLD, and APASL guidelines.
Dear Didier, dear Schiff, ladies and gentlemen, thank you first of all to Patrick Marcelin and the organizing committee, not only for inviting me to this very stimulating meeting, but also to the success over the years. Maintaining such a quality for more than a decade is quite an achievement. Thank you for that. I've been given the task to talk about commonalities and discrepancies between the major guidelines which have evolved in recent years to help us managing the increasing burden of hepatocellular carcinoma. We have the ASLD guidelines, which had been developed in 2017 and appeared in January 18. We have the APASL guidelines from July 17, and I had the privilege to work with a very experienced panel, and we published the clinical practice guidelines endorsed by EASL middle of last year. So these guidelines have a different time frame, and it is not unexpected, therefore, that EASL guidelines have been a bit more advanced, particularly in terms of the last 2-year development in systemic therapy. These guidelines, and I should add that there are many more. For example, Chinese guidelines have been developed, and in different countries, Korea, Germany, Italy, there are other guidelines, but I think it's fair to concentrate on these major guidelines. They have some differences in concept and focus. ASLD decided to take a different approach. It is very focused. It is basically concentrating on, first of all, cirrhotic patients, nothing else, and asks 10 questions, which then come down to answers and concentrate really in a pragmatic way on clinical relevant aspects. That means they are not as comprehensive as APASL and EASL. They're much shorter. They're easier to read as it's only 23 pages. APASL and EASL are more comprehensive, much larger, and give recommendations followed by a background discussion on literature and the evidence. EASL goes then beyond what had been standard in recent years and adds palliative data and also data on clinical trial design. All these different guidelines use the CRADE system to evaluate evidence and give strength of recommendations. There are only minor issues in that ASLD is in the end qualifying evidence in 4 categories and APASL and EASL only in 3, but this is not a major difference. What is relevant though is that, as I pointed out earlier, as ASLD has been concentrating on cirrhotic patients, they are not covering various aspects, including prevention. APASL suggests HPV prevention for all infants. EASL goes a bit further, all newborns, and then stratified risk groups. Antiviral therapy is very intensively covered by EASL and is not concentrating only on hepatitis B, but also includes hepatitis C and covers the issue of potentially increased risk of recurrence in patients treated with DEA after curative treatment of hepatocellular carcinoma. That discussion was not available, I believe, when APASL had convened, and therefore there is no explicit recommendation of DEA therapy in HCV patients. APASL discusses coffee and the chemopreventive effect of coffee, and EASL indeed encourages patients to drink 4 cups of coffee, whatever quality, whether decaf or caffeinated, and it actually coincides with a recent recommendation by the World Health Organization in 2018, which gave a general recommendation to drink coffee. So think about that in the coffee break. Surveillance is suggested by ASLD in general, as it's covering only cirrhotic patients, and APASL and EASL go beyond that and define risk groups, and EASL specifically adds the patient subgroup with F3 fibrosis, appreciating that in that setting we are not very certain whether it's already full-blown cirrhosis, and the sampling error is resulting in F3 adjustment, although we at the same time appreciate that it is quite difficult to cover that full spectrum of patients, in particular NASH patients, as this is probably too large a group to be surveyed by standard ultrasound. With respect to the mode of surveillance, EASL suggests ultrasound. APASL suggests to use ultrasound, and it's obligatory to use AFP. And ASLD considers AFP, so you may use it or you may not. EASL discusses that we probably will see further evidence in the next years in view of the aspect that we now are able to treat hepatitis B and C patients, and what had been probably diluting the signal quality of AFP in the past, those flares of hepatitic activity that should be diminished in the setting of antiviral therapy, and I would predict that AFP is getting more specificity in that particular setting and probably coming in the future also in EASL guidelines. There are very particular recommendations going into different subgroups, as I was mentioning it for APASL and EASL. EASL also recommends the use of the PAGE system, platelet age and gender in patients with hepatitis B to define subgroups of low, intermediate, and high risk. And as I was pointing out, no specific recommendation with respect to NASH patients, as we do not have a clear evidence to do surveillance in that particular subgroup. What about diagnosis? ASLD is here very clear-cut, UCT or MRI, they're exchangeable. APASL and EASL appreciate that we do have evidence that contrast-enhanced ultrasound is also effective. There's a lengthy discussion on the problem of cholangiocarcinoma, which, however, as it had been outlined in the last years, has a particular contrast pattern with respect to the washout period, where it is in fact possible to distinguish cholangiocarcinoma and hepatocellular carcinoma. So APASL and EASL allow contrast-enhanced ultrasound, although we at EASL felt it appropriate to recommend the cross-sectional imaging at first place, as it's resulting in a more panoramic view. The other aspect of diagnosis is the indeterminate nodule. ASLD only discusses what is available, follow-up imaging, alternative imaging, biopsy, but does not give any recommendation here. APASL is also not giving recommendations here, it just says further examination, and EASL is very particular. If you start with CT, switch to MR, and if you're still negative, go for biopsy. There is a general, let's say, more biopsy-friendly discussion by EASL. I will come to that. ASLD, in contrast, is rather reluctant and is against routine biopsy and is discussing the risk of bleeding, seeding, and the uncertainty of negative diagnosis. APASL suggests biopsy for indeterminate nodules above or equal of 1 centimeter. This is the EASL algorithm, and it's very simple. You see, you start with one modality. If it's positive, you're done. If it's negative, you go to the other modality. If it's negative, again, you do a biopsy. But what is relevant by this and depicted by these dotted lines, you see also in those cases where there is a clear hallmark pattern and therefore the diagnosis is made, we do suggest under particular protocols to integrate biopsy into your diagnostical assessment, as we believe that it has been a wrong decision in the past to only stick to radiographic imaging, and there's a lot of information lost, and the fact that we are today unable to stratify patients according to their individual signatures with respect to systemic therapy is probably a result of the neglect of biopsy. APASL is in a very pragmatic way suggesting that there are two different settings. On the right-hand side, you see that is the, let's say, standard setting, where there is only standard diagnostic procedures available, CT or MRI, and has then a clear-cut suggestion as how to proceed. And it is getting more complex in a, let's say, academic setting where there is more available, and that includes a discussion on the contrast agents and the inclusion of contrast-enhanced ultrasound. In general, APASL is paying much more attention to local regional peculiarities, which seems to be appropriate in a setting where there is, with respect to resources and available therapeutic option, probably a rather broad spectrum all over Asia Pacific. And that results then in a very fine-tuned discussion what is done, for example, in Korea and so on. With respect to treatment, we have probably the most pronounced discrepancy or the different recommendations in terms of liver resection. EASL is sort of strict and evidence-based and is basically suggesting resect a single nodule in a patient with good liver function. Nodule can have any size, but that's basically it. And in contrast, and that is, let's say, the other extreme, a parcel suggests operate everybody as long as the liver will tolerate that. And that can include and goes so far to include indeed patients with BCLC stage C. And that would, for example, be a patient where there is macrovascular involvement. That is probably pragmatic and reflecting real-time behavior in certain areas, particularly probably in China, and depends, of course, on the availability of other treatment modalities. ASLD is a little bit in between and is allowing resection, including T2 tumors that would be multinodular disease below nodules of 5 centimeter. All different guidelines agree that we do not have yet any evidence for adjuvant treatment that may come with the new available immune-oncological agents. EASL gives a relative lengthy discussion on how to resect and whom to resect, and pays attention not only to portal hypertension, liver function, future liver remnant. So it's trying to get down to a comprehensive assessment, and comes down to a certain risk assessment of liver decompensation. That was the stimulus of Vincenzo Mazzaferro. Now, what about liver transplantation? EASL is again, let's say, very evidence-based strict. It's basically the Milan criteria. It is lengthily discussed that we do probably need better assessment strategies, composite endpoints, and more probably dynamic assessments, but that has not currently been defined, may be used in protocols, in experimental protocols, but for the time being, and this is actually in respect of the availability of organs, probably a pragmatic approach as well. We stick to Milan criteria. ASLD is also basically concentrating on OPTN 1 or 2, that it would be Milan patients. And the same is actually then for a parcel. It is interesting to see that ASLD is recommending bridging therapies only for those patients with larger tumors, not for OPTN1 patients. A parcel is actually not giving a recommendation with respect to bridging, and EASL is giving a general recommendation for bridging, although modalities remain open. What about downstaging? ASLD suggests that those patients who have been downstage as a result of therapeutic intervention to Milan, they should be considered for liver transplantation, and EASL is discussing that. It, of course, this is an area which is heavily regulated also by law in different areas of the world. And however, EASL suggests to do that basically again in experimental protocol, and there should be a scientific evaluation. EPAS is not discussing downstaging, but suggests to those patients exceeding Milan to undergo TACE. Now, what about local regional therapy? ASLD is here very non-specific and does not separate ablation from ethanol injection, from TACE, from SIRT, from radiotherapy. And it's just giving the recommendation that those patients who are not resectable and who have multinodular disease should be treated with local regional therapy, and that is then in the choice of the treating physician what to use. EASL and APASL are more specific. EASL suggests ablation for very early and early stage disease and discusses ablation actually as a first-line alternative for very early stage, meaning less than 2 centimeter in size. APASL is recommending ablation for Child-Pugh A and B patients with less than 3 tumors below 3 centimeter, and again is for very early stage disease discussing a first-line treatment option with ablation. Ethanol injection in those patients where ablation is not technically possible. Again, ACLD is not discussing that issue. TACE for intermediate stage disease by EASL in a selective manner. Doesn't matter whether you do it with conventional TACE or drug-eluting beads. No evidence for blunt embolization, no evidence for intraarterial chemotherapy, and insufficient evidence for scoring systems. Not so many differences here with respect to what PASL is recommending. It's actually quite similar. And again, ACLD is not specifically discussing the issue of TACE. What about CERT? Here is a difference. At EASL, we appreciated that the trials, particularly Civanib and SARA, were negative trials demonstrating feasibility and good tolerability, good safety profile, but in the end, negative trials. Those data were not available when the PASL guidelines were coined. Here, CERT is definitely discussed as an alternative treatment for unresectable hepatocellular carcinoma, particularly in those patients where TACE failed. What about radiotherapy? At EASL, we felt it's actually promising. Unfortunately, only trials with relatively small numbers. In Asia Pacific, this is much more frequently used, and in many countries such as Korea, for example, there are combined modalities, TACE plus radiotherapy with actually good results, although the level of evidence is not very high, but there is definitely a more favorable recommendation by PASL with respect to radiotherapy. Again, ACLD is not discussing that. Now, the most recent development, as I initially mentioned, in respect to systemic therapy, is a bit beyond what has been integrated into a PASL and ACLD, and that results in the fact that only EASL is in fact discussing very specifically the different systemic treatment options. ACLD, just like in local regional therapy, is just talking about systemic therapy and defines those in good liver function and advanced stage disease as patients suitable for systemic therapy. EASL is more specific and defines here a first-line setting, similar with a PASL. And in respect to lenvatinib, EASL is considering this an alternative option with a good level of evidence, as it has been shown by the REFLECT trial that it's non-inferior. I'm sure that Bruno Sangro will be discussing that in detail, and therefore can also be recommended in first line. But at EASL, we were very specific and took exactly what had been the inclusion criteria for applying lenvatinib in first line. With respect to the second line options and further options, again, ACLD and PASL are not discussing that. EASL is clearly seeing regorafenib as second-line option, cabozantinib as well, also addressing the issue of ramucirumab for the patient with AFP above 400. And with respect to immunotherapy, you're aware that FDA gave conditional approval to nivolumab and also to pembrolizumab. EMA did not, is more reluctant as we do not have matured data, no phase 3 data, and therefore EASL did not feel that the data basis is sufficient to give that, to integrate that. I need technical help in that I am unable to advance. Now I'm, believe, too advanced. Maybe my time is just over. But I have a few more slides. Happy to share. Okay, we start from scratch. I can do it. Thank you. So that's then resulting in the well-known treatment algorithm by EASL, which basically is based on the Barcelona staging system. The treatment algorithm by PASL is a bit different. It starts with the assessment of the existence of extrahepatic metastasis, yes or no, and then adds liver function to it, and then gives treatment recommendations. As I was pointing out, there is a very liberal handling of resectability. This is basically in the decision of those who resect and can be, in fact, quite advanced. The EASL recommendation summarizes the currently available systemic therapeutic options and gives clear recommendations and levels of evidence together. In addition, EASL is covering a couple of aspects which are not covered by other guidelines. That includes a discussion on response assessment, mRECIST versus RECIST. It is adding a chapter on best supportive care and also a chapter on trial design for the future. Mr. Chairman, ladies and gentlemen, let me quickly summarize. We do have three major guidelines, AASLD, APASL, and EASL. In respect to surveillance, they suggest to use EASL only ultrasound, APASL ultrasound plus AFP, and AASLD you may add AFP to ultrasound. AASLD is not recommending the use of contrast-enhanced ultrasound. APASL and EASL do recommend to do that, although not as first line. The handling of biopsies, EASL is suggesting that this is definitely required in non-cirrhotic patients and should also be discussed in cirrhotic patients, even in those patients where there is a clear radiographic diagnosis. APASL is suggesting to use it for indeterminate nodules above 1 centimeter, and AASLD is more reluctant. Bridging in those patients waiting for transplant, only for larger tumors or multinodular disease in AASLD, no recommendation by APASL, and a general recommendation by EASL. Liver transplantation after downstaging is recommended by AASLD, no recommendation by APASL, and a possible recommendation by EASL. And with respect to local regional therapies, I've discussed that in details, and it is worthwhile mentioning that ablation is here a positive first-line option in those patients with very early disease. Systemic therapy, not a detailed discussion by AASLD, only sorafenib in the APASL guideline, and a detailed discussion on the available substances by EASL. In summary, there are in fact more commonalities than discrepancies. There is a difference in concept and focus, and in the end, that is a very solid basis for an intersocietal discussion to be continued. Thank you very much for your attention.
Thank you for that very outstanding talk, and it's my pleasure to invite now Professor Bruno Sengro from Spain, who is the head of hepatology and was one of the co-authors for the Checkmate 040, the Lancet paper, and I think he brings many new ideas in immunotherapy, and we look forward to hearing from you about new therapeutic strategies for HCC. Welcome.
Thank you, Mr. Chairman. Thank you to Patrick Marcelin for his invitation, and congratulations for another successful meeting here in Paris. It's my time. Well, these are my disclosures, nothing to be blamed for. You've heard from Peter Galle how there are very different things that have come up and that are open to debate and in the treatment of hepatocellular carcinoma. And the novelties basically have to do with three main focuses. One is the impact of surgery, particularly since the adoption and training of most of the surgeons in laparoscopic surgery that has reduced the rate of complications and has opened the way for achieving better patient outcomes. Secondly, for deciding when resection or particularly transplantation could be offered to patients that are in the intermediate stage or have large tumors that are downstaged. But most of the revolution comes from the far right end of the spectrum, from the arena of the systemic therapies. And this is really a revolution because it's going to impact, it's already impacting the way hepatologists practice hepatology worldwide. And it will be even more so in the next few years. It is also challenging the way we deal with some other colleagues in the field. So basically, I will focus my presentation on the advances in the advanced population. And this means not only strictly the advanced stage, patients with vascular invasion or metastases, but also patients at earlier stages, intermediate or early with stages with large tumors that are not candidates to local regional therapy, either at first line or after 1 or 2 rounds of local regional therapy. And this is a major thing. Switching from local regional to advanced is something that is changing due to the fact that we now have better options for treating advanced stage patients. Let me just very briefly remind you how HCC is a very chemo-resistant tumor. No benefit in survival for any given combination that has been tested. And this includes all types of agents. So there's no good reason to treat with chemotherapy any single patient. And this, in my experience, particularly applies for children that are frequently treated with chemotherapy based on the experience with hepatoblastoma, which is a completely different scenario. So the only systemic agent that we were used to use was sorafenib. That was for a good reason. Very consistent effect in prolonged survival in the advanced stage across regions, across etiologies. But this drug had a very particular spectrum of action, of activity. No effect in combination with TACE or other local regional therapies for patients with less advanced stage. No effect at all as an adjuvant therapy post-resection or ablation. So the effect seemed to be limited, or was indeed limited, to the most advanced cases. What were the mechanism of actions of sorafenib? And this, I think, is important, and it has influenced and still influenced the way we practice and will practice treatment of HCC. It does have, and we know this from in vivo as well as in vitro evidence. You see here how HCC cells grown in vitro under sorafenib have less vascular cells, so there is an anti-angiogenic effect, do proliferate less, has an anti-proliferative effect, and have a high rate of apoptosis. And this has been replicated in humans, at least to some extent. And we know that when we analyze the response by modified RECIST, which takes into account the vascular shutdown, there is an increased rate. And we saw from the first phase 2 trial that patients that had positive phospho-ERK staining with a more proliferative activity had a better outcome. Unfortunately, none of the pivotal trials were able to collect biopsies. And so we were not able to learn if any biomarker obtained from the biopsy could identify those patients that responded better or obtained a better treatment benefit from sorafenib. And that's where we remain. 10 years later, and after a series of failures, we now have a second drug that has shown to be active as first-line therapy. Lenvatinib is also a TKI with an anti-angiogenic effect. It was tested in a large trial in which the main objective was first to prove if it was non-inferior, and second, to prove if it was superior to sorafenib. It did meet the non-inferiority criteria. It did not meet the superiority criteria. See how overlapped the survival curves are. And this equal effect was consistent across subgroups, depending on tumor burden, AFP, etiology, whatever. So very similar results as a first-line therapy. Now, if we have to choose, now that the EMA has approved, and it's approved in most of the countries, if we have to choose between one or the other, what can we base our decision on? On liver burden? Well, we know that a high liver burden, tumor burden, more than 50% liver occupation was, or my main portal vein invasion was a contraindication or a exclusion criteria for lenvatinib. So we have something there, but otherwise, toxicity seems to be very similar. More skin toxicity with sorafenib, more hypertension and proteinuria with lenvatinib, but in global, very similar rate of discontinuation due to drug effects, and the same contraindications. So it's nothing really strong on the characteristics of the agent that would allow us to make a decision whether to choose lenvatinib or sorafenib as first-line agent. So we have to now to choose between two drugs, if they are possible. But if any of these drugs, 10 to 15% of the patients are contraindicated, basically because the patient have atherosclerosis with either myocardial infarction or peripheral arthropathy, then we still have some options to treat these patients based on a lower level of evidence, of course. Peter has alluded to these. There were two head-to-head trials comparing SERD versus sorafenib, and both of them were negative, improving a superiority of SERD over sorafenib. In terms of secondary endpoints, there were an increase in response rates and time to progression, but the main thing is that the survival was not any better. But if we focus on these patients that have a contraindication, I think this is a good rationale for providing an alternative to patients who would otherwise not be treated with any effective drug. In some countries, and this includes some Asia-Pacific plus also some US institutions, nivolumab, and I will come back to this later, is also an option. What I would like to stress is that in order to prescribe SERD for a patient that has a TKI contraindication, you have to be quite sure, and this is something what we've learned from these trials, that the patient has a very good functional liver reserve, that has no main portal vein invasion, and most importantly, that the MAA uptake, so the amount of microspheres that are trapped inside the tumor vasculature is high. Otherwise, it's probably better not to treat the patient at all. So for patients that had gone through sorafenib, again, for a decade, we were testing very different kinds of agents, looking for increased activity with a succession of failures. But in the last 2 years, 5 agents have provided positive results in either single-arm or randomized trials. I'm going to discuss this in detail. So for patients that are progressing or are intolerant to sorafenib, now we have the ability to choose between 3 drugs. 2 TKIs, regorafenib and cabozantinib, and 1 pure VEGF inhibitor monoclonal antibody, which is ramucirumab. Regorafenib and cabozantinib are EMA approved. Ramucirumab is not yet, and they're all available in the United States and other countries in Asia. What are the differences in terms of the design of the trials? Well, regorafenib restricted the population to those patients that had very good tolerability to sorafenib, patients who had tolerated at least half the dose of sorafenib on a stable fashion. And for ramucirumab, the inclusion was restricted to those patients that have an elevated AFP. And this is because on a first trial, in all comers, the results were not positive, but the subgroup of AFP high patients were identified when there could be a signal that has now been proven to be positive. But beyond this inclusion criteria restriction, the population treated was very similar in terms of etiology, tumor burden, and with the exception of ramucirumab, AFP levels. The effect is quite similar, quite potent, very low hazard ratio for overall survival, and a very clear advantage over placebo for the three drugs. What are the differences between these three drugs? They're all TKIs with the exception of ramucirumab. And we take a look at the regorafenib and cabozantinib, you see how the difference is basically for cabozantinib, the inhibition of MET, but we know that MET inhibitors are not effective in the same setting. For regorafenib, it's basically the inhibition of FGFR on RET. And these are shared by lenvatinib, which was not any better than sorafenib. So these at least raises the question as to what extent these drugs would be better than just continuing sorafenib. And we will never know the answer to this question because these trials will never be run. But this has an important pragmatical implication. If in a certain country or in a certain environment in your hospital, you don't have access to any of these drugs, the best thing you probably have to do with a patient that progresses to sorafenib is keep the patient on sorafenib until there is clinical deterioration. So radiological progression not necessarily mean you have to stop sorafenib if there is no other agent available. Can we choose between these three agents in terms of the safety profile? You see here a comparison between them. The rate of events leading to discontinuation is similar for Rego and cabozantinib, slightly lower from ramucirumab. And what we can see here is the ratio between the incidence of adverse events in the drug and placebo-treated arms in these randomized trials. So no big difference between regorafenib and cabozantinib, and certainly a better tolerability for ramucirumab. If ramucirumab is available, then certainly AFP-high patients could very well be treated with this drug. How about immuno-oncology agents as a second-line treatments? We have data from two large single-arm trials with more than 150 and 100 patients with nivolumab and pembrolizumab respectively. Second line or third line in the case of nivolumab. And the results in terms of the ability to induce objective remissions were similar, more than 50%. What is important here, besides the very encouraging overall survival rates, is the durability of the responses. More than 6 months in most of the patients in the pembrolizumab, and in the nivolumab trial, it has not been reached in two other cohorts, more than 16 months of median duration of response in hepatitis C patients. The result is this. If you have HCC and you have been treated with nivolumab beyond being treated with sorafenib, and you achieve objective remission, the chances that you have a very prolonged survival are very high. And this is something that is unprecedented. We have never seen with any other TKI. Furthermore, for patients that have progressive disease, but still have some unique pattern of progressive disease, meaning patients or tumors grow but then shrink, or tumors grow but then became stable, which is 10 to 15% of the patients added to the 15 of the patients that are responders, then the median overall survival is also as high as 18 months. So there are a fraction of patients that we can identify during the treatment for which we can expect a very good long-term outcome. And if we compare in terms of tolerability, Needless to say, much better tolerated drugs than the TKIs and even the anti-angiogenic brand. And this certainly would be important when taking treatment decisions if the treatment is available. It's available in the FDA, it's available in India, in Taiwan, in other countries in the Asia-Pacific area, not in the EMA area. So we now have very different options after sorafenib. We have no experience with post-lenvatinib trials. Should we take into account, should we consider that these patients would be equally served by receiving these drugs after lenvatinib? From a clearly evidence-based perspective, the answer is no. I'm not sure we will be able to deal with this lack of evidence, and I could anticipate that in clinical practice, the decisions are going to be much more pragmatical. So now with different agents, the final step is how can we combine these agents to obtain better outcomes? We have learned over the last year that combining TKIs with locoregional therapies has no benefit. Adding TACE to sorafenib does not prolong survival and adds toxicity. Adding radioembolization to sorafenib does not provide a benefit in OS. At least for this combination, the subgroup analysis has suggested that for patients with non-alcoholic etiology, and quite more importantly, for non-cirrhotic patients, there could very well be a treatment benefit that has nevertheless to be supported by new prospective clinical trials. And these trials have to be run before we adopt these kind of strategies. But most of the hype has been on the combinations of anti-angiogenics and immunotherapy. And the hype was basically coming from a clinical trial on the combination of Avastin, bevacizumab, plus atezolizumab, which is an anti-PD-L1 inhibitor. And this trial reported initially a response rate of 60%. And because of that, it was designated as a breakthrough therapy by the FDA last year. On the second interim analysis, the response rate has dropped to half, 30%. But nevertheless, it's twice the response rate that we have been observing with immunotherapy alone. And certainly opens the way, if this is supported by the definitive results of the phase 3 trials that are running, opens the way for combination therapies really changing the landscape of the treatment of very advanced HCC. And again, we have different drugs available for the second line, but patients that progress to these second lines, what are we going to do with them? Are we going to test a third line's agents in the absence of direct evidence? Most likely, if we think of the potential patient benefit, particularly when immunotherapy is provided after failure to TKIs in the second line. Very pragmatical approaches that we will have to do, or decisions that we will have to do in the next years. Finally, these are the phase 3 trials that are already running. 2 of them are eagerly awaited, comparing Pembro with supportive care in the second line, or nivolumab with sorafenib in the first line. If this is positive, then the whole evidence will change, and we have to start from scratch providing evidence for second-line treatment. Combinations already being tested as first-line agents, and quite importantly, immunotherapy already being tested as an adjuvant therapy after resection or ablation for high-risk patients. So my conclusions are, we now have 2 drugs that are the standard of care, can be considered standard of care for first-line therapy, sorafenib and lenvatinib. The choice of a second-line agent cannot be based on etiology, tumor burden, or available biomarkers. It has to be based on different things. And in Europe, at least, accessibility would probably be the key thing. And combination therapies should prove efficacy before they are recommended. But beyond the conclusions, I think what is even more important is the questions that all these novelties prompt up. And the first one is that combinations have to be based on the mechanism of actions, and we need to understand the mechanism of primary and acquired resistance to TKIs and immunotherapy. And for that, we need tumor biopsies. fortunately, they're mandatory in all the recent trials. Second, we have to test sequencing. It's not all about combining. We have to learn from other neoplasm, for instance, like for renal cell cancer, where the sequencing has been tested extensively. And this is a mission of most societies. The companies may not be willing to do this. Societies should. And finally, in this early transition from local regional to systemic therapy that we are now facing because of the increasing activity of the systemic agents, we have to provide prospective evidence that support what we have to do. Thank you very much for your attention.
Okay, so we have only 1 or 2 minutes for the question due to limited time. Valérie, if you can come, because there is a question for you, and Peter also, and Bruno. So Valérie, there is a question regarding is biopsy required for diagnosis in HCC on metabolic syndrome?
As you know, I'm a pathologist, and I learned from Bruno Sangro. I think since most of these tumors, at least half of them, developed in patients with non-cirrhotic liver, the guidelines is to biopsy a nodule even if you have the morphological characteristic by imaging of a HCC. So in this situation, without overt cirrhosis in the background liver, I think yes. And then in patients with cirrhotic liver, I think we have to do as we do for other risk factors.
Thank you.
While we're waiting for other questions, I have a question to Dr. Bruno. In the immunotherapy, let's say it's against PD-1, like nivolumab, what is your experience that on the biopsy you have a PD-1 receptor expression? In our experience, like about 40-odd patients, it's only 7% who showed it. So is there a justification that you do biopsy and find out PD-1 or let's say other receptors, or you still give it without any justification?
The short answer is no. We still cannot use PD-L1 expression as a biomarker, and we will be providing interesting new information at AACR about the biomarker panel of the 040 trial, and basically I don't think we will have the strongest biomarker, but we have an idea that probably what you need to have is T cells in place that can be stimulated with the antibody.
I have a question for both of you, Bruno and Peter. I mean, how you see the place of immunotherapy, I mean, in the next months in the therapeutic armamentarium in HCC? Second line, third line, first line? If you project.
We will get the data from the pembrolizumab trial in a second line, phase 3, and from the 459 trial, head-to-head comparison with sorafenib in first line. So these answers will be there. For the time being, we do not have an evidence-based answer.
Yeah, just to add that, I think one of the problems we are having, and we will increasingly have, is that the access will mandate the possibility of accessing the drug, will mandate the treatment options, and this is quite unfair. And I think this is one of the things we, as hepatologists, have to deal with. Try to make more fair treatment algorithms.
There is a question. I do not. What is the therapy for HCC resected in HBV cirrhotic patient? Do you mean HBV suppressed, or so you want to know if there is an antiviral therapy should be given?
But the tumor has been resected. There is no adjuvant therapy that could improve the outcomes, so no specific anti-tumor therapy, and certainly you have to have effective antiviral therapy, put the patient onto effective antiviral therapy. If the tumor occurs.
Okay, thank you.